I'm a professor in health administration and policy in the College of Health and Human Services, and I direct our Center for Health Policy Research and Ethics. And I am delighted to have Suzanne Bakken here today with us, our first speaker of the spring semester of our seminar series. Dr. Bakken has many hats. I'll just give you a brief introduction to her. She's Alumni Professor of Nursing and Professor of Biomedical Informatics at Columbia. She received her doctorate in nursing at University College San Francisco and completed a postdoc fellowship in medical informatics at Stanford University. So has a longstanding interest in medical informatics. Her program of research has focused on the intersection of informatics and health equity for more than 30 years, with significant funding from AHRQ, NCI, and NIH, NINR, and NLM. And her program of research has resulted in over 300 publications. She leads the NINR-funded Precision and Symptom Self-Management Center and a Reducing Health Disparities Through Informatics pre- and postdoctoral training program. So given all of these exciting roles, I asked her to please join us and speak to a number of topics from her perspective as researcher, educator, and editor, as another role she plays as editor-in-chief of JAMIA. So thank you so much, Dr. Bakken, for being here. Our participants are going to be on mute, but please put your questions in the Q&A. We invite you to do that. Dr. Bakken has planned her presentation such that we can have an open dialogue after she presents her key themes and ideas on these topics, an open dialogue about the most pressing questions across these researcher, educator, and editor perspective. So I hope you'll engage in a dynamic conversation with us. So Dr. Bakken, I'm going to turn it over to you. Welcome.
Yeah, thank you so much, Allison. I really appreciate your invitation. And as you remember, we met when you were on a consensus committee for a report called Communities in Action, Pathways to Health Equity. And at that time, I was the nurse scholar in residence at the National Academy and was delighted to be staff for that particular report, which I think many of us that participated in it really felt like it was a life-changing experience because of the people we worked with and the importance of the work we were doing. But today I'm going to talk to you about what I do in my day job now. And I'd like to start out with just talking a bit about a health equity framework. And so the World Health Organization has a framework focused on social determinants of health, and a group of informaticians broaden that model to look at it from an informatics perspective. And this is just showing you a broad view, but the idea of the paper, which is called Leveling Up, and this was in medical care in 2019, was really on the potential of upstream health informatics interventions to enhance health equity. Because when we really look at the state of the science, most informatics interventions are either at the micro level, and much of what I do has been there, or some will be at the health system level, but there's been very little which really is going upstream, where it would be very important to intervene on social determinants of health. And I put this up because I'm going to use this framework to talk a bit about what I do. And this is not meant to be a comprehensive review of what informatics can do for health equity, but more to share a perspective that I have for our discussion. And so for part of my career, I was focused on doing some randomized controlled trials. These represent 3 different trials that focused on using mobile health to do something. And in the instance of the first one, to provide guideline-based decision support to screen, diagnose, and manage depression, smoking, and obesity. And this was the the intervention was focused on advanced practice nurses. We got some additional funding from NCI to expand our research to integrate some of the cancer information service resources. And then I recently led a mHealth trial that was focused on earlier diagnosis of atrial fibrillation and included some self-management strategies in that as well. But much of what I do now is a little different, and it's really focused on the area of visual communication. So I want to just talk a little bit about that and why I can give a long talk of kind of how I got to this, which I sometimes do, but I want to give you a quick overview, because this was kind of a natural extension of many things that I'd done in the past. But the project that really moved me towards thinking about the role of visual communication as a health equity strategy was a project called WISER, which was funded by ARC, 2 consecutive R01s. And in this particular project, and WISER stands for Washington Heights Inwood Informatics Infrastructure for Comparative Effectiveness Research. And the idea behind this project, which was the brainchild of someone named Adam Wilcox, was really to imagine if you were doing the Framingham study today, and you were doing it in a community with a large volume of health disparities, and you were doing it with full use of informatics tools. So the idea is we have patients or community members that may see different clinicians. They have electronic health records, both within our own system, but also they may have them in home care and long-term care. They may also participate in trials or surveys. So one of the big things about WISER was to bring all those different data sources into an integrated data warehouse, and then to create a data access tool, which is called Research Data Explorer, or REDX for short. And this would enable the researcher to have easier access to the data collected from these variety of sources in a single user interface, and that then the researcher could work to improve the health of the community. And as my role on the team increased, and I became the PI about halfway through the first grant, and for all of the second grant, I really knew from different experience that I had that it wasn't impossible to improve the health of the community without the community members themselves. And so I didn't want to just give the data back to the researchers. I wanted to give it back to the research participants and to the community members. And so we knew from the survey that I had led in the community that we had documented health disparities in our local community, that our survey sample, about 5,800, was primarily Latino. Most data collection was in Spanish via community health workers. And what we knew from the data that we had collected was the majority of people had limited health literacy and low education levels, which of course would present some challenges to giving the data back. And so I want to just spend a minute talking about, there's a lot of talk about information visualization at the moment, but there are different types of visualization. And often the kind of thing I'm doing is really focused on visualization for communication versus visualization for analysis. And often in visual analytics, you're really looking for insights from the data. And this is something that for a researcher who might be doing discovery using various data science methods, or it might be more, it could potentially be some kind of dashboard. But one of the differences between visualization from communication and visualization for analysis is that often the users are different, general versus someone who might be a specialist user like a scientist. There's unknown versus known user goals and tasks for the design. And in visual communication, often there's variable literacy in different ways, not only variable health literacy, but there can be a variation in visual literacy as well. And it's interesting that one of our researchers did some work actually in the Visiting Nurses Association of New York City, and they actually found that about 25, although all the home care nurses were bachelor prepared, there was about 25% of them that had very poor numeracy and poor graph literacy. So they weren't able to understand those types of visualizations as compared to others. But what I wanted to do within this project was to do visual communication, which is defined here, conveyance of ideas and information in forms that can be seen. But for us, it was critical that it could be comprehended, acted on for both self-management and communication with healthcare providers by individuals with varying levels of health literacy. And we needed to do this in English, in English and Spanish. And the majority of our work actually ended up occurring in Spanish. And so by way of background, I am a nurse, and with that comes a kind of pragmatics, and let's just get on with it. And so I convened a visualization working group. We expanded behind our research team. As it turned out, the people that were interested in working with us, although they all had informatics background, among our group, we had people with visual design backgrounds, such as jewelry and fashion design, theater design, graphic design, and art. And so I convened the group, I bought some books, I hired someone to help us, and we just set off on creating some designs and moved forward with participatory design with research participants. One of the things that I'll say about that particular process and how we've learned over time is that in Wiser, we conducted, I think, 22 visualization design sessions in the community until we got to the final designs. About 18 were in Spanish, the rest were in English. And now with our refinements of processes, often we can get some of this done in more 5 or 6 design sessions. So we really refined some methods over time. And this just shows you a little bit about some of the kinds of things we were giving back. We were very, one of the things we collected were some of the PROMIS measures. And so the first visualization on the left shows you the PROMIS anxiety score. In our work, we use a lot of number lines. They seem to work well across various levels of health literacy. So you see the line, you see the use of color as well as text, and then highlighting where an individual's score is as well. We also wanted individuals to be able to see where their health was in comparison to ideal. So it took quite a few designs to get this comprehensible for people with low levels of health literacy. But we ended up with this kind of flower design. It was necessary to add the dotted lines around for people to kind of get at the proportion of health that they had on that dimension. And these were examples of things that were measured that had different denominators. And so we had to transform things to proportions to do this, but eventually it worked well. Our comparative effectiveness studies in Wiser were focused on blood pressure. And so we had probably, for most things, we would go in with maybe 3 designs per kind of variable. But for blood pressure, we probably went through about 30 designs. And this design, which is maybe more complex than one might think people would like, in the end was actually preferred and perceived as actionable. So you can see some reuse of the number lines and the words, but also adding, this is a blood pressure, this is one of the ways it's taken. But we also added the risks of high blood pressure. And you might notice that we have both the official diagnosis and a more colloquial term as well. And our paper that we wrote, one of the main visualization papers we wrote from this work was called Sometimes More is More, because we found in working with underserved Latino populations that participated in our design sessions is if we presented data without context, they weren't engaged and they had a difficult time getting even a gist understanding of what we were presenting. And in some instances, if we didn't provide contextual details, as in this example, something about the risks, but it could be other things about it, is they would start to build a story about the person this must belong to. So we called our paper Sometimes More is More. So doing the simplest design isn't always the best we found in the kind of work that we're doing. Because we wanted to do this at scale, we created a software framework that's called Entice3 for short. It stands for Electronic Tailored Infographics for Community Engagement, Education, and Empowerment. And the basic idea behind the system is that it brings in this instance, survey data, processes it, matches it against our graphical components repository, and then spits out the tailored visualization, because we were very interested in not presenting summary results to the community, although that was useful for things such as community boards and the health system, but really wanting to give their individual data back to people so it would be seen as actionable. Along the way, and we've done many visualization projects since that period of time, we have created a set of what we call visualization artifacts. So these are not only infographics and graphical components, but we've created a series of methods guides that have really been developed through our process of becoming more expert in this. And here's just an example of some of those papers. I want to just spend a minute talking about kind of moving up, moving more upstream to something meso, and for me, meso level. And for me, this has been, this is kind of my 2020. And so I was involved with two particular projects that I consider more meso level interventions. And for these, one project was called COVID Watcher, and this was a citizen science initiative that I was part of to develop a set of apps that would allow individuals, specifically individuals in New York City, to report things such as their symptoms, their barriers, any issues they were having, distress, difficulty getting food, issues with this work. It included a fair number of essential health workers as well. And so this is ongoing and is available on both the Android and the and in the App Store for the iOS version. But we had the opportunity through the NIH RADx Up initiative to apply for a supplement to a center that I lead. And this particular grant, which you see here, the second one, which is called Readybiz Toolbox, kind of builds upon about a decade of work. And the idea behind this was take all these things that we learned about information visualization, put them into a toolbox to assist people who are doing COVID-19 tests to give information back to the test recipients in a way that would be culturally congruent and health literate. And as a framework for this grant, I actually used a set of public health principles for ethics, and it worked well, and we got the grant, and we're one of 16 social, ethical, and behavioral implication grants funded through Radix. But I was at a very interesting presentation yesterday, and I'm on the National Academy of Medicine's Health Literacy Roundtable. But I heard a great presentation on critical health literacy yesterday, and this was, I've done work in health literacy, this idea was new to me. And so I'm sharing just like a thought that I've had since yesterday, which is I need to circulate it more, but I'm really thinking about critical health literacy as a construct for moving visualization communication to an upstream health equity intervention. So there is a, oops, I didn't put a citation, but there's a published literature review and also a concept analysis that I was reading shortly before coming on here. But the basic idea between critical health literacy, it's really considered a social asset for a community, which helps individuals towards a critical engagement with health information. And I think that's a lot what we're trying to do within Readybiz Toolbox. And the domains of critical health literacy include work on information appraisal, but also understanding the social determinants of health, and has this collective action. So I think the last is where, you know, the policy really comes in. So I'm excited to learn more about this and to think about framing my work in this way. But I just want to share this new thought, less than 24 hours old, with you. But now I want to talk a bit just about the Readybiz Toolbox. Readybiz stands for Reaching Communities Through the Design of Information Visualizations. So it's a toolbox for the return of COVID-19 results. And our basic argument for this particular approach, and all of the RADx up, or Rapid Acceleration of Diagnostics for Underserved Populations, has a combination of many types of grants. There are testing grants, there are technology grants, and ours is a social, ethical, and behavioral implication grant. But what we basically argued is, yes, there are disparities related to COVID-19, definitely related, some of them are related to testing as well as the consequences. And so we really argued that it was unethical to return results if they weren't culturally congruent and health literate. And I've been tested for COVID, I think maybe 5 times so far, and different variations of results from the different types of tests that I've taken, because I look at that aspect of it. And some of them are actually quite confusing, and I think would be very challenging for the Latino populations in particular that we're working with in our project. So what we're going to do is some CVPR work, some information design work, and then create the toolbox. And we have a very exciting partner, which is the Association to Benefit Children in Harlem. And they also provide services in the Bronx. And like our local Washington Heights Inwood community, there are also many Hispanic immigrants, and that's a group that we've been particularly working with for quite some time. And so the idea is we do that the end product is this toolbox that includes software as well as implementation guides and sets of graphical components and infographics that would allow clinicians, healthcare organizations, community organizations to produce tailored results for COVID-19 testing. And that would also support people who want to do more research in this area to do the type of visualization work that we do. So that's ongoing. How we're going to get there. We're in the phase that's community engaged research and a broader survey of about 1,000 people. Then we move to doing these participatory design sessions and some preference surveys. And then we'll, during the last year, we're implementing it technically and disseminating it to a variety of user groups. I now want to just move to the, a little bit to my educator role. And one of the things I do as an educator is to lead an institutional training grant. And our particular grant is in, happy to say, year 19 of continuous funding. And this supports pre and postdoctoral nurses to do research that's focused on health disparities and informatics. In our particular program, they can either be getting a PhD in nursing or they can be getting a PhD in biomedical informatics. So we support these two different degree programs. This is just to give you a bit of a flavor of some of the types of trainees that we've had through the years and some of the foci of their research. So there are some things that are tied very much to EHR data, and you see much of what we do is focused on Latinos, but you can see some recent work with the Hmong population, and then also quite a bit of research in our school is focused on LGBT. And so we've had quite a few trainees focused in that as well. I want to just mention a new class that we've had in the school. I designed this class with a colleague named Jackie Merrill to be a specialty class that a specialty class for people on a training grant, but the School of Nursing Curriculum Committee decided that everyone should take it. And so one of the things for you all to think about is where are maybe some of these competencies in your curriculum, and would something like this potentially be interesting. So this class focuses on data, information, and knowledge visualization. And so it is, in our instance, it's a combination of visual literacy competencies and data science competencies. So there are some aspects, these are examples of assignments. They do critique published data visualizations and graphical abstracts. They learn to use graphical Jupyter Notebook. They program in R, and for their class exercises, they actually use the COVID Watcher data set. The final, during this process, they create a graphical abstract from their own research. And I think that's important because more and more journals are wanting a graphical abstract, because then it's easier, like for someone like me who's an editor, to tweet about a paper if I have a nice visual to put in with it. And the final assignment was an infographic of their portfolio. What was in the notebook? How had their competencies grown over time? And they asked for a grading rubric. So I gave them one, even though they're PhD students, they wanted a rubric. And so this is how I tied kind of the competencies to this final assignment, which was worth 20% of the grade. It was quite interesting because people did such different things, even with a rubric, which I said, be creative. And this is an example of someone who did a very detailed infographic of her experience. So you can see she's got several weeks in there and has a visualization for each week of the course. She has her competencies as a legend, and she's, for each week, she's kind of saying which competencies are growing in that. And then she actually kept a journal about her state of the mind going through the process. And so that shades of blue line you see at the top reflects her state of mind. So you can see week 8 was a really good week for her. So, and you can also see some dark blue periods, which were not so good, but she actually was the only student that integrated an external data source. So she took the COVID Watcher data and then did some GIS analyses as well. But this was just, I just want to show you some examples. This other student, she did a very abstract view of thinking about what she had learned. And she really kind of separated the head things, the conceptual things, beyond the technical things. And I thought this was very effective as well. I had them grade their competencies on a scale of just novice to expert with these 5 categories. So she's showed that in the different colors. And I think one of the reasons she called it surprising, I think once she did this, she saw maybe she had gotten competent and proficient in a few things. And I think that's why she called it surprising. Another student did it as a game and just did some visualizations of how she was making progress. This was her graphical abstract for her research, which she was really trying to look at racial and ethnic differences in associations of social support and hazardous drinking in lesbian and bisexual women. And I thought she had very good use of color. She had, I think, very appropriate images to show different types of social support. And she really highlighted the key aspects of the study that would make it, and I found it very attractive as well. These were some of her final R things, which are, but she kind of feels she moved from no entry to actually being able to do it. And this is just her idea of kind of going to the future. So I wanted to just give you an idea of a class like that, because I think some of those visualization and data science competencies are going to be very important for individuals with different kinds of backgrounds. I want to just now talk for a few minutes about being an editor. And so I'm the editor-in-chief of the Journal of the American Medical Informatics Association, or JAMIA. And one of the things I've been editor since January 2019. So this was my initial editorial. And what I sold in the job interview and what I was promoting in this first editorial was the idea of consequentialist informatics. And consequentialism is, those of you who have epidemiology background would have heard about consequentialist epidemiology from, there's been a number of editorials, and I'm forgetting the very famous person's name at the moment, although I know him quite well. But anyway, the basic idea is what can happen a lot in kind of computational domains is you can end up focusing a lot on methodological improvement. And I really wanted to say for the journal during my leadership, I really want to put more attention to the so what question. And while we still care about methodological improvement, improvement in F1 score, area under the curve, and incremental improvement is not really what we're looking at. We want people to address the very important problems of our society. So one of the things that happened the first year, and this started before, during a period of time when I knew I was going to be the editor, but others did not know. And I worked with two colleagues who were on that first paper, the first Medicare paper I showed you, to do this, a special double issue in JAMIA, which is focused on health informatics and health equity, on improving our reach and our impact. So from the collection of papers that we ended up publishing, about 10 out of the 23 focused on more detecting disparities. Only one focused on understanding why disparities exist. And 12 were focused on, so that's like slightly more than half, on meso-level interventions. When we looked at the targets for the 12 health system studies, most were focused on preventing unequal consequences of ill health. Only 2 were focused on reducing exposures or decreasing vulnerability. And those types of things would be considered trying to go more upstream in that. Our conclusions from the special issue was we need more theory-informed research. We need more evaluations of the equity impacts of interventions. We need more novel upstream interventions. Also expanded measurement of socioeconomic and health literacy, and leveraging large data sets to investigate health equity relevant questions. And really to actually get those subgroup analyses done at scale, because we see a lot of white versus other, or white, Black, Hispanic, and having everyone else lumped into other in what we get. In trying to be responsive, we're almost a year into sheltering in place, and we've had many submissions to JAMIA, I think almost 400 during this period of time, and we have published 69 so far. The first one was submitted from USD on March 18th, and I actually got it out later that week online. You may know that anything related to COVID-19, the accepted rather than the proofed paper gets up. And the second one that came from a group at Vanderbilt was actually online, is accepted within about, I think, 2 days. So we've made it an effort to not only get these things reviewed very quickly, but in things that were particularly important. And in these 2 instances, there was a lot of, this is how you can whip your epic into shape to do some things for COVID-19. So they provided very useful things to the community. As I think really as a result of that, when you look at journal performance, you may look at impact factor. I'm also judged on an altmetric score, which is how much attention in the media the papers get. And our altmetric was about 5 times my key performance indicator because of papers such as these, which were just very useful. The thing that I'm thinking most about now, and I definitely had been thinking about health equity from the beginning and starting to do some things, but I think this blog from Health Affairs made everyone look a little more deeply at what they were doing. And I'm sure many of you have seen this, but to really moved from thinking about something like race as simply something that's in your demographic table and a demographic characteristic that belongs to an individual and not like representing their own lifetime of experience and also perhaps other experiences from history. And so at that point in time, we had gotten these two papers at JAMIA who were really looking at health disparities related to telehealth. And they were very high quality in many ways. And I sent them back and just said, you know, love what you've done, but I really want you to talk about your findings in the context of structural racism. And one group of the authors said, both groups responded very well to it. And one group said, we're experts in that. We just didn't think you cared. So I want to make it clear that indeed that is something that we do care about. And so I really, as I said, this is like a top priority for me. I worked on diversity in my associate editors, recruiting more diverse associate editors, also in our editorial board and our student editorial board. We think a lot about, you know, informatics isn't going to solve, you know, structural racism, but what is the role of an informatics journal? So some of the times it's focusing on health disparate populations. And for any of you that do research in the area of informatics for sex and gender related health, we have a call for papers for a special issue on this topic that's out now. In a couple of months still left, almost a couple of months to write a paper. But we're also looking at our revisions to author guidelines, certainly more rigorous evaluation of racism, but also as an informatics journal, thinking very much about where are the sources of biases in the data sets, in the algorithms, in the samples, thinking about relevant subgroup analyses, thinking about AI reporting standards, and we published a paper by Tina Hernandez-Broussard that was focused on minimum information for medical AI reporting, and she's joining us this year as an associate editor, but we really want to move that way because we get a lot of black box prediction papers. And another thing that I'm thinking about as someone who's interested in visualization as well is just taking that equity and bias lens, not only to tables and figures, but also some of their labels. And I read a wonderful paper that I can give someone a citation for if they're interested in, but just that's really thinking, you know, why are certain demographic characteristics always in the same order, and to really have a rationale for the order in which you present something like race or ethnicity. Thinking about figures that would represent more of an equity lens rather than bias. And so that's just kind of what I'm thinking about these days. And so I really feel that health equity presents a critical lens for all aspects of professional endeavors. And so I've tried to show you the different ways that I'm using an equity lens to look at what I do in my roles. As you can see, most informatics interventions really are at the micro or the meso level, and macro level interventions are critically important. And that's where those of you who work in the policy arena play a very important role. And I just wanted to show one more paper at the end. And the sad news for this, for me, and I was, this is the kind of thing we really do want to get out there. But when we look at underrepresented minorities in biomedical informatics doctoral programs and look at the graduation trends, in 15 years, nothing has really changed. Underrepresented minorities are still 12%. And so that's something that those of us in informatics really need to work on the pipeline. And so I'll end with that, and I'll stop sharing and we can move to some questions.
Thank you very much for such a really thought-provoking presentation, Suzanne. I went really very nice. Thank you. And I was really struck by how you, in your own work, were using visualization in some ways is to level communication and improve health equity. In some sense, that was how you tackled visualization. We did have a question from one of our attendees from your perspective as in the work that you've done, and also keeping in mind the health equity component. What either programming languages or visualization skills would you recommend to students coming through their training now, or even faculty for retooling?
Yeah, there actually are a set of visual literacy competencies, and I'd be glad to send those to you. And I think, and then for us, it ends up just being, you know, so there are resources, but there's sets of competencies as well. And one of the things I personally try to do with my, let me step back. I lead a center that's focused on symptom self-management, but one of the things we have in that is a visual design studio. And so we have built an internal community for collaboration and community building and to offer expertise. And people join us from outside, so if anyone gets particularly interested in this or wants some critique on something they're doing, we're happy to do that. Another thing is just putting it into like practice, because people tend to do more tables than figures. And so for the trainings I'm working with, I really push everyone to kind of turn one of those tables into an interesting figure. Because I think it's important to be able to communicate using have a variety of kind of modes of communication in a paper, and then really working with people on having a graphical abstract, because more and more journals are wanting that. And so I think that's just like a real useful skill that any researcher really needs to be able to do that.
Right. I like the way you drove home that point, that it was this communication, the visualization across the message, the education spectrum, the audiences. So this goes for our academic audiences as well as for communicating about individual health. So it sounds like there are a few things I want to let our participants know we will follow up with. We will send out the citation for leveling up, your call for papers on gender minorities, and the visual literacy competencies. And I think there was one more, but I'll follow up with you. We will have some things to share with you. We did also have a question about the, I was curious, your citizen science around COVID, how many participated, and will you be extending that to the vaccine as well in New York?
Yeah, well, it's interesting. So it's still available, and you know, ongoing, and the questions do get updated. There are some questions about vaccine already in there, so it has been updated over time. So it's a series of short surveys that have expanded, and people can choose however many of those they may want to do. So it really is an example of very noisy, messy data when you try to make some sense out of it.
Fair enough.
It's important to do it
Great.
In that way. We're thinking a lot and for our Readybiz Toolbox grant, both our CBPR work as well as our surveys have measures of vaccine hesitancy, and also measures of trust sources and those types of things. So we how we see what we're doing in the toolbox is COVID-19 is an important, the testing is an important application area, but we think of it as being much more, it's much more generic than that. So we see being able to pivot to more vaccination related stuff pretty easily. But for now, RADXUP wants us to focus on the testing related issues. And as you know, for now, the guidelines are to keep testing even if you are vaccinated.
Speaking of the toolbox, we had a question on what your timeline is for the Readybiz toolbox, the materials getting all the way to local governments, let's say, or even state governments. Sort of what is your timeline roughly?
Yeah, and so
obviously there's a lot of interest.
Yeah, no, there is, and we tend to make everything available as soon as possible. So, but I think we're still a year away. And one of the reasons for that is all the grants in this initiative, a central part was doing a pretty intensive CBPR, since these are communities that have been resistant to testing and to vaccination. And so we're just in that part, but we're already trying to, as we get various things done, we like to get them out as soon as possible. We connected with a group the other day. I co-lead a lab based on the FIRE interoperability standard. And we had a speaker that was working on the international digital passport. And so we're going to follow up with them, because I think they need what we're doing as well, to not only be able to have your tests and your vaccine on your phone, but you might like some of the health behavior information there as well.
That's excellent. And I encourage people to follow. You can follow the RADXUP activities also. Just you can subscribe to updated information from them, in addition to all the other exciting news we're getting. I did a couple questions that were related to this idea of theoretical models or frameworks that can be applied in research addressing systematic racism, whether it's the visualization of it or it's the intersection of informatics and health equity. This idea of frameworks in informatics and health equity is somewhat new.
Yeah. Yeah, and so for people that focus explicitly on structural racism, there are definitely frameworks related to that. And then we think about something as a broad model like the National Institute of Minority and Health Disparities, multi-level, multi-component framework. And then also these other types of frameworks, like the one I presented, which was really taking putting an informatics lens on top of what the WHO had things. So I think people are probably, there is work in informatics and data science that is not theoretically based, but for the kind of work that I do, which more spans clinical and public health informatics, and in general has an element of human behavior or health system behavior in it. It's just critical to be able to think about these things through a theoretical lens, so you can kind of have a good sense of which body of knowledge you're contributing to. So I honestly always approach things from not necessarily the same theoretical lens, but from some theoretical lens that gives me a way to approach the problem and structure what I'm doing in relationship to the problem.
I liked your term, the consequential informatics, which is so what in this context also the for whom question, right? The heterogeneity of these impacts. Or even we were going through an exercise in a journal I'm involved with of just even flagging what are the topics we've been publishing on. And often in our abstracts, we don't characterize the sample to be able to say how many of our studies were exclusively or had a sufficient N, if you will, to say something about certain subgroups. There's not a systematic way that we capture that in abstracts now or in keywords. So there's really some interesting thinking going on in the journal community. And I hope to see some changes in there.
Yeah, and I think you'll see many journals making this more clear in their author guidelines. And so we know, like we've known for quite some time that well-educated white people use portals more. And so maybe a couple studies early on, that's good to know. After that, that's not the question. The question is how can we what are the features and the function of a portal that make it possible for someone with a low level of technical literacy and health literacy to do something with it. We just have to move beyond to thinking about, how can technology help with this, not to just continue to describe that disparity.
Right.
So often that's, things, and the same thing with, telehealth with the expansion. We started to get lots of telehealth papers, and a few of those were, good to have, but now, the evidence is pretty clear. So you have to focus on the why and what can we do to make it better, not just. And so a lot of times it's not that the descriptive stuff is not necessary, but you just can't continue to, enumerate the dead, the comorbid. You have to kind of move on to a deeper understanding and the intervention for it.
Well, thank you again, Suzanne. This has been terrific. Our audience, I think, is riveted. I wasn't able to get to all of the questions. I apologize. You have graciously allowed us to post a recording of this on our website, so you can go back and listen again and capture some of the citations that you included very generously, very thoughtful. Thank you very much, and continue the great work. And I love that you're working in my old neighborhood, Washington Heights. And I hope to see you in person soon, right?
And you can see this, you'll recognize that's the apartment buildings, and then you can see the George Washington Bridge as well. And so this
Castle Village was my old house, that's right.
So it is truly a view. I'm on the 6th floor of the School of Nursing, and I face this direction, but Wonderful. This is actually from our roof. We have a rooftop garden, and that's where this view is.
Well, thank you again. Take care, and thank you everyone for joining us.
Thank you so much for having me. Bye-bye.
Bye-bye.